Can everybody hear me okay? Thumbs up in the back. So my name is Joe. I'm one of the newer docs to UVM. I'm actually, this is an outdated title. I'm the Director of Pediatric Emergency Medicine, which sounds a lot fancier than it is because I'm the only pediatric emergency medicine doc in the state, as far as I know. I'm going to steal a little bit of Dave's thunders coming next, just kind of sampling the audience. So how many providers, PAs or MDs do we have out there? How many RNs? Any EMTs, pre-hospital providers, paramedics? Any pediatric endocrinologists or pediatric critical care docs? We're better off with that. Okay. So what we're going to do today is talk about pediatric DKA. And really what I want to get your mind around is it's not just fluids, insulin, ICU. Right? There's so much more to it. There's complications of it. There's little subtle points, particularly in the pediatric population we have to think about. I'm adult trained as well, so I deal with both adult DKA and peds DKA. So I have kind of an interesting perspective on the two. Okay, what we're going to do is we're going to talk about how we diagnose DKA, what our initial management is going to be. We're going to talk about etiologies for DKA, why do people go into DKA? Such a great question, why? We're going to discuss electrolyte abnormalities that will show up in DKA from time to time. We're going to talk about airway management in DKA. There's a quick preview, show of hands. Has anybody ever intubated someone in severe DKA? How terrifying is it on a scale of 1 to like? And then lastly, we're going to get into a little discussion of specific complications of pediatric DKA, specifically cerebral edema, kind of a hot topic issue, hot button, high risk medical legal issue that is often talked about. So, what is DKA? American Academy of Diabetes. It's a pretty simple definition. You got a D, you're diabetic, blood sugar over 250. You got a K, you either have serum beta hydroxybutyrate or ketones in the urine. And you got an A, your pH is less than 7.3 or your bicarb's less than 18. All right? I like to say you can make the diagnosis of DKA in about 15 seconds. A blood sugar, a urine sample, and a point of care blood gas, and you have your diagnosis. On to the next patient. Why do we love it so much? So the academic in me loves it because I get to sit down and I get to grill a medical student. Actually, any medical students or residents in the class? Lecture. You get to grill them on all the fluid electrolyte abnormalities, think about hyperglycemia, think about the acidosis. Community peeps love it because it's easy money for critical care. You got your diagnosis in 30 seconds, you do 29 more minutes of care, bill for 30 minutes critical care up to the PICU, next patient. Just as an aside, when I think about DKA, and this is children and adults, it's really not a disease of hyperglycemia. The D is almost superfluous. It's really a disease of volume depletion and acidosis with incidental hyperglycemia. And you guys remember we give volume, typically isotonic volume, sodium chloride or lactated ringers, to treat the volume deficit. It'll also correct the blood sugar. We don't give the insulin for the blood sugar, we give it for the K. Give it to force sugar into the cells, turn off the ketoacidosis, and resolve the DKA. The hardest patients to treat, and I'm sure you guys have seen them before, are those with the 6-9ers with a blood sugar of like 350. You've got a lot of room to play with because you know your therapies are going to plummet their sugar. And we'll talk about that in a little bit. So let's go over some cases. These are, some of them are real cases, some of them are kind of loosely based on stuff I've seen. So we got a 15-year-old, known type 1, 3 days, nausea, vomiting. She says, maybe I missed 1 dose. Her vital signs look pretty crummy. She's tachycardic, she's hypotensive, her respiratory rate is up. She looks ill and dehydrated. Neuro exam, absolutely 100% critical in all of your pediatric DKA patients to document an initial neuro exam. Not a full cranial nerves, but what's their mentation? Are they awake? Are they talking to you? We'll talk about that in a sec. Her belly soft and non-tender. Again, we got our diagnosis in 15 seconds. What's her diagnosis? Someone shout it out. D. I'm a cheerleader. K. A. Fluids, insulin, PICU, next step. Well, not so fast. So this is so critically important. Why did the patient go into DKA? I don't know if Ryan's still here, the intensivist, but the intensivist will tell you over and over and over again, this is the step we can miss, right? Medication noncompliance is the most likely reason, right? Our kind of petulant teenagers, we see them all the time. Oh, they're back again in DKA, they're not taking their meds. Those are the ones we anchor on and say, oh, there's nothing wrong with them other than they don't take their meds. There's also nothing you can do about that. But what you don't want to miss is an infection, something potentially treatable. Still flipping over to the adult population, something like cardiac ischemia, again, pediatric talk. This was actually a study done in Sweden. This is pediatric DKA. So actually, I would argue, wait, Sweden? I think it's better in Norway. Somewhat generalizable to the population of Vermont. And in that study, most of it was missed insulin doses. So if you're going to bet on something, that's correct. But a lot of those people had gastroenteritis, and then look down here, 13% had some sort of documented infection, typically a urinary tract infection. So before you say fluids, PICU, fluids, insulin, PICU, think about why they went into DKA. Is there something treatable I'm missing? Because I guarantee you the PICU doc, and particularly our PICU and pediatric residents, will anchor on that. Well, the ER said they were fine, so they're fine. And then they get upstairs and have a demonstrable infection a couple days down the road. Okay, I think we just talked about that. Case 2. So this is an 11-year-old with known type 1 diabetes, has nausea, vomiting, and abdominal pain, multiple family members with the stomach flu. So here we see kind of a gastroenteritis, one of our common causes for well-controlled diabetics to just slip into DKA. He's alert, but he's sleepy. He appears volume depleted. His blood sugar is critical high. His urine dip is positive ketones. There's his gas. We got our diagnosis. These are his labs. So what do you guys want to do? Fluids, insulin, PICU.
Only insulin.
Why?
Hypokalemia.
Yeah, exactly, right? This patient is hypokalemic. What's going to happen if you give him insulin? Well, hopefully nothing. You may kill him. I mean, so the problem is that once you give insulin, that's going to drive all that potassium into cells. Typically, the patients we see in DKA are hyperkalemic, falsely hyperkalemic, you might even say. I'm going to say almost all DKA patients are total body hypokalemic. I had to add the almost in after I gave this talk at UCLA, and a really persnickety attending was like, well, if they're in renal failure, I guess technically they could be total body potassium up, whatever. Kids aren't going to be in renal failure. Almost all patients in DKA are total body hypokalemic. The ones that present where the lab is measured, the extracellular hypokalemia, those are the really sick ones. They've been dehydrated and volume depleted for a long time. In this particular case, a kid with gastro, he's got double losses. Not only is he peeing everything out, but he's pooping everything out too. There's no literature on children. There's some literature in adults that says about 5% will show up in hypokalemic and DKA. Those are the really sick ones. And what the American Diabetes Association recommends for adults and for children as well is if their potassium is less than 3.3, don't give them any insulin until you replete the potassium, and replete it aggressively. Aggressively replete their potassium. Sometimes, I mean, this is more ICU level care, but these kids may need central access just to give them enough potassium so you can start giving them insulin so you can fix their acidosis, which is going to drop their potassium. What I will, I thought I'd want to make one more point about this. Oh, on the other end of the spectrum, so the American Diabetes Association for children and adults says right around 5.5, theoretically holding potassium until you give insulin. I find that they're all going to drop, so have it ready to go. So if you're going to order insulin on a hyperkalemic DKA patient, don't forget that there will be potassium very soon. You might not start with it, but have it ready to go. Okay, so this is case 40-kilogram child who's been to the ICU with DKA. He's put in on IV fluids. He's put on insulin drip at 4 units an hour. Here's his blood glucose, 450, 300. The pediatric resident falls asleep. 150, 67. Whoops, nurse calls, half empty 50. So is there anything we could have done to prevent this child's hypoglycemia? I'm only bringing these couple next things up because you may hear about them. If you're transferring up to UVM or you guys transfer to Dartmouth, you may hear this from the pediatric intensivist. It's kind of emerging as treatment, which is lower dose insulin drips. 0.05 per kilo as opposed to 0.1. There's only been a couple of studies in this. That's all very pilotish stuff. Not ready for prime time, but you may hear that from your specialty provider. So not, well, what are you thinking about? What are you crazy? No, there's a few studies on it. The one that's kind of quoted is a non-inferiority trial where there's only about 60 kids in each group. And what they looked at was there any difference in hypoglycemia, resolution of the acidosis, treatment failure. Interestingly, there was no difference. Not just that there was no difference in resolution of the acidosis, but there was no difference in the incidence of hypoglycemia, which doesn't make a lot of sense unless you think about the fact that fluids. that's going to plummet their blood sugar, probably a lot more than any insulin you give them. So in case you hear that, those low-dose insulin drips, that's out. Okay, we're going to just take a brief detour, kind of other things on the frontier, things you may hear about. I had one of our endocrinologists talk about this the other night, and I thought he was crazy. The use of subcutaneous insulin. So this was a 16-year-old known type 1 with a pH of 7, frequent flyer, not infected, who the endocrinologist kind of sighed and was like, can't we just give her a big dose of sub-Q, watch her for 4 hours and see if she gets better? And I said, her pH is 7. I think she needs to go to the PICU. And he took another sigh and reluctantly agreed to admit the patient. So there was recently a Cochrane review in adults. I think it came out in 2014 or 2015, of which there were only one randomized controlled trial they included in children getting sub-Q insulin versus IV insulin. We got that? This is a small study. It's from Brazil. It's from 2005. And what they found was that it took longer to resolve the acidosis in the sub-Q group, but they all did resolve, and they didn't really have any complications. So in a austere environment, you don't have access to an intensive care unit, it may be a treatment strategy. Not now. There's no evidence to support using it now. Okay, this is an actual case from when I was at Children's Orange County as a fellow. This is a pretty incredible one. It's a 9-month-old brought in for lethargy by the parents. Just really looking bad for the last couple of days. I think it was February, middle of RSV season, kind of RSV+++, just looked awful. I was actually in the PICU at this time, so I remember when the ER sent me this kid, I almost couldn't believe it. They get some initial vitals, just looks crappy, and the really smart ER doc checks the glucose, it's 450. Checks ketones, positive ketones, uh-oh. We got D, we got K, look at that blood gas. I'm an astute provider out there. What's the scariest thing in that blood gas? And I'll give you a hint, it's not the 6-8. Yeah, what's up with the CO2? Exactly. So what should the PCO2 be in DKA? 5, 6, as low as you can go. Most children can blow their CO2 down to 5 or 6. Right? Your life is being saved by your phrenic nerve. Every breath you take is blowing your CO2 down to compensate for that whopping metabolic acidosis going on. But what happened to this kid? This 9-month-old just couldn't do it anymore. Probably had reached the point of respiratory failure and now had a rising CO2 with a mixed metabolic and respiratory acidosis. Holy F. Now what? Yeah. Right? So this is just kind of reiterating what I said. Your life is saved by your phrenic nerve. Why should the intubation terrify you? So most children in DK do not need to be intubated. I just told you their life is being saved by your phrenic nerve. What are you about to do to them? You're about to cut their phrenic nerve for a hot sec and hope you can get the tube in fast enough before they get acidotic and die. So these really metabolically acidotic children are terrifying. It doesn't just have to be from DK. It could be from lactic acidosis, an ingestion causing a massive acidosis. These ones really scare me. Making the decision is not any different than normal, right? If they can't oxygenate, they can't ventilate, they need airway protection, they're expecting clinical course. So if you had a kid with pneumonia and DKA, they need to be intubated for pneumonia. Are there any tips, tricks, things you can do to prevent what's coming? So the first thing, this is something my mentor, a woman named Marian Gaucher-Hill, is pretty famous in the PDM world, would say, is resuscitate to intubate. So if you can buy yourself a little bit of time, even 5-10 minutes to get some IV fluids in a kid, get them resuscitated, optimize your conditions, you're much better off. Intubating a hypovolemic acidotic kid is worse than intubating a somewhat Jewish bulimic acidotic kid. So get the kid as best you can before you go for it. Don't let the intern try. Right? If you got academic centers, if you're not comfortable with pediatric intubations, have your pediatric, if you have an anesthesiologist that is, this needs to be an experienced intubator because it's got to be fast. Right? Remember, hypoxia is a late finding. Hypercapnia starts right away. So the minute you paralyze them, they're getting hypercapnic. You want minimal apnea time in these. There's not really any, you can throw supplemental oxygen on, you can put high flow nasal cannula. It's not going to help you because what you really care about in this case is their pH, not the desaturation. And then remember, after you get them tubed, set the ventilator to 35, right? These kids need that respiratory rate to compensate for their acidosis. So great, you get the tube in, everybody high fives, set the respiratory rate to 12, the alarm bells start going off, patient starts crashing 15, 20 minutes later. They need that high respiratory rate to compensate for that severe metabolic acidosis. We'll talk about this in a sec. So there's been some literature in the severely metabolically acidotic patient about giving a pre-intubation push of bicarbonate. I'm going to do everything I can to just tank them up. I would say in children, avoid it for reasons we'll talk about later. There's not a lot of literature that it does anything, and if something bad happens to the patient, which these are the ones that something bad will happen to, you will probably get into some trouble for things we're going to talk about in the next case. Questions about that? I've been kind of flying through this. Anyone have any questions so far? Thoughts? What's up?
I mean, can you bag some of that CO2 down?
I guess you could try.
You're getting ready to intubate, you're like, you know, if you're like hyperventilating that kid with the, I mean, it's a 9-month-old.
Yeah, I guess the question becomes how well can you match their respiratory rate? You could try. So it certainly wouldn't hurt to just bag them as much as you can to try to bag them down. I don't know how much mileage you're going to get out of it, because at that point that kid's just kind of getting ready to go. So, something.
Is there a role for BiPAP at all?
So it's a good thought that all the literature in BiPAP, like Weingard's late sequence intubation, is really looking at maximizing your oxygenation time. Right, you're trying to get every last ounce out of like a COPD or a heart failure guy before they desat. There's not a ton of role here because you really don't care what their oxygen status is. That's not what's going to kill them. It's the acidosis. That's why you want to minimize the apnea time. I mean, epoxy will kill them eventually too.
High flow, HFNC.
High flow, again, more for hypoxia and oxygenation. You do get some increased PEEP. I don't think it's going to help you with this. The key with this is intubate fast and set the ventilator fast. Okay, this is a really sad case. This is a true case. I was not involved in this case. My good friend, who's now a PICU attending, was the PICU attending involved in this case. I do not know the ER provider involved. So we got a 40-kilogram 12-year-old. She's got known diabetes. She comes to the PICU in DKA. This was her initial presentation to a high-level community hospital in Los Angeles with a PICU. So we got pH of 6.9, we got a low PCO2, we got a low bicarb, we got a sick kid. So the ER doc opened up the adult DKA order set, clicked volume resuscitation, which was 2 liters, wrote the orders out, admitted the kid to the PICU. So, and 2 liters for this 40-kilo child was almost 50 cc's per kilo. So the kid got a lot of fluid up front. Kid was sick. Kid got a lot of fluid. We're going to go back and forth between these two a lot. Over the next 12 hours, what happened? She became combative. She became obtunded. She got intubated. She died. So the question is, what happened? Why did this poor child die? Could this have been prevented? So cerebral edema in pediatric DKA. This is almost universally a pediatric phenomenon. As far as I know, there's not a ton of case. It's maybe case reported in adults. It's just not a disease of the old brain. It's a disease of the young brain. What a couple of first kind of epidemiologic points is, I truly believe this, that subclinical cerebral edema is common. Almost all kids in DKA are probably in some form of cerebral edema, and you know this because they're not right. When you go talk to them, they wake up, they're a little bit sleepy. Whether that matters or not probably doesn't matter that much. What's studied in the literature and what you guys care about, because this is the big deal, is clinically overt cerebral edema. Some higher end studies put it at about 1%. There's been some recent literature to say it might be lower than that, 0.5%. So it's rare, but it's the plane crash problem, right? Low likelihood, bad outcome. If you have clinically overt cerebral edema, this is a study done in 2002, you have a 25% chance of dying. And you have a 25% chance of having a neurologic outcome, a bad neurologic outcome. Not good. We want to avoid this at all costs. So this is kind of interesting techniques. It's kind of a step back to pathophysiology. What causes cerebral edema? So have you guys heard of these before? The osmotic theory. I like to call this the maple syrup theory. And the vasogenic theory is the like Vikings rushing the gate theory. Become clear in a second. So what's the osmotic theory? The osmotic theory. I have prolonged hyperglycemia. My blood is like maple syrup. My brain wants to hold on to water. It doesn't want to become a shriveled up raisin. So it starts making little proteins, starts cleaving proteins to increase the tonicity of the brain so that fluid stays in the brain and doesn't rush out to that maple syrup blood. Make sense? The brain, when we get fluid resuscitated, so then the kid meets some poor ER doctor who floods them with fluid and changes it from maple syrup to maple sap. The brain is still salty, right? Has all these proteins in there trying to hold on to fluid. And water says, hey, there's this salty brain kicking it right next to this maple sap. Let's go inside the brain and kill this kid. All right, that's the osmotic theory. This is all of the stuff behind why fluids are bad is based on that theory. The vasogenic theory is that there's something about DKA, probably the acidosis and the dehydration, that just fries the blood-brain barrier. And it fries the blood-brain barrier of a young kid. I'm sorry, I don't know time. The ability of the brain to regulate the movement of water across the blood-brain barrier is lost. Fluid comes rushing in, kid dies. This has actually been studied, an MRI study of children in DKA. They use this ADC, which basically watches how water flows across. There's free flow of water, so their conclusion was it's much more likely to be a vasogenic. The barrier is just fried. CD, it's not one of the reasons that we fight so much with this about the PICU and the peds endocrine is because it's not really our problem. The vast majority of children present with cerebral edema 6 to 12 hours after their incident presentation, although there are case reports of kids dying at home with cerebral edema. So it can't just be the fluid. If your pediatric intensivist says that, say, how did the kid die at home with cerebral edema? Case reports. Can I just go 5 minutes? Is that okay, everybody? Okay. Looks like I got a red light on. Who's more likely to get cerebral edema? So Jay Cutler actually is a type 1 diabetic. That's why I put him in here. Anyone take a guess? You got Macaulay Culkin, young Macaulay Culkin, not old, strung out Macaulay Culkin. Versus Jay Cutler. Who's more likely to get cerebral edema if they come in a DKA? Yeah, it's Macaulay Culkin, because we've looked at this. This is, so anytime you see edema, you know it's either done in England or New Zealand or Australia. This was a study done in England, which looked at the incidence of cerebral edema.
You've got plenty of time.
Oh, okay.
I set the timer wrong.
Oh, excellent. This is a study. Okay, so this is a study in England looking at risk factors of patients presenting. What were their inherent factors of the kid themselves? Nothing about the labs, nothing about the DKA, nothing about what the bad doctor did, just who was going to get it. The only thing they knew new onset diabetic. So new onset diabetics are higher risk. There was a trend towards younger diabetics, but as you can imagine, there's not a lot of DKAs under the age of 3. I will say that most of us in the PEM world, PICU world, tend to treat the littler ones with a little bit more kid gloves, because they also tend to be their incident presentators. So young, not really associated, probably because there just aren't enough of them. New onset diabetics, certainly yes. So, remember, we're going back to this kid who died of cerebral edema. We're looking at her labs. Is there anything on her labs that makes you worried this child's going to have cerebral edema? Interesting. So hyponatremia, we'll talk about that. Any other guesses? Renal failure, particularly the elevated BUN. Anything else? We'll go back to this too with acidosis. There's something about acidosis and dehydration that fries the blood-brain barrier in kids. I don't know what it is. I wish it did. So this is a study. This was done in the US. This is looking at factors on laboratory data. All of these studies we're talking about are retrospective studies because this is a rare event. If you did a prospective study, you'd have to do years and years and years with thousands of kids to catch enough cerebral edema to make anything. So these are all retrospective, case-controlled series looking at kids who got cerebral edema, kids who didn't, and what singled them out. It turned out the acidotic ones, so pH and low bicarb, kind of the same, and it turned out the dehydrated ones. Interestingly, hyponatremia in multiple studies is not ferreted out to be a risk factor. So the kid you got to be real worried about, we got a young, so plus or minus that one, new onset, acidotic, dehydrated kid. High risk. This is another study looking at this. This one, I think, is Nicole Glazier's paper from New England Journal of Medicine. This was also a couple years ago, maybe 2005, around there. which showed the initial serum concentration, the initial BUN, and the initial PCO2. So same thing over and over again, acidotic, dehydrated, first timer. What about fluid? What about what we do to the kids? So have anybody ever heard anything? So what do we do to kids? Does anything we do to them cause it? So fluid is the big one. People, the PICU, and believe me, if something bad happens, the PICU and peds endocrine is going to comb over that chart with a fine-tooth comb and find out how much fluid you gave. The only thing in all of these retrospective studies, so take it back. There have been 3 well-done retrospective controlled trials of children presenting in DKA who got cerebral edema. In 2 of the trials, the only thing that popped was the treatment with bicarbonate. So remember way back when I talked about the acidotic children and how you may not want to think about giving a push of bicarbonate. Treatment with bicarbonate, when they controlled for how sick the kid was associated with cerebral edema. In these 2 well-controlled studies, so these 2 studies are the 2 studies we talked about before, this study and this study, there was no increased rate of cerebral edema based on the rate of fluid you got, how fast the glucose went down, how fast the sodium went up. So 2 pretty well-controlled retrospective trials say no, so maybe we didn't hurt her. Maybe it was just she had bad disease. One study, this was from 2006 by a guy named Edge, who's a big researcher in England. Again, you can see England because it says O-edema, where they looked at fluid resuscitation in children and they broke it down by tertiles. So the high volume fluid getters had cerebral edema. Now the first thing you'd say is, well, they were the sick kids, right? The sick kids got really, really aggressively resuscitated. They claim down here that they controlled for biacidosis, by dehydration. What I don't know and what isn't reported in the studies is if these were like outlier effects. Were these that a couple of these really huge whopping volume kids got it and the more appropriately resuscitated ones didn't get it? I don't think that was reported in the study. So there has, your PICU doc might say, well, there was a study from 2006. This is what he or she is talking about. Is this study looking at tertiles of fluid. Okay, what's the poor ER doc to do? So this study, this is the protocol. This is subclinical cerebral edema in children with DKA randomized to 2 different rehydration protocols. A prospective randomized controlled trial run by PCARN. So I think Nikki Glazier, who's a pediatric endocrinologist, is married to Nick Cooperman, who's like the PEM guru. So this is like the ultimate power couple to run this study. They're doing 2 separate protocols looking at either initial fluid resuscitation of 20 cc's versus 10 cc's and initial kind of running it in over 24 hours or 48 hours. Prospectively studied. I got some hot off the press for you. Not published yet. This is just the thing. So I emailed Nate, and this is what he said. So it's coming soon. So I think within the next year or year and a half, we will have in our hot little hands. I suspect it will show no difference. Strongly suspect it will show no difference. A lot of literature that says appropriate fluid resuscitation in children, 20 cc's per kilo with correction of volume over the next 24 hours, does not cause cerebral edema. You are not killing these kids. If they do happen to get cerebral edema, early recognition is key. There was a study done looking at outcomes at Dallas Children's before and after the institution of a protocol. One of the sub things they studied was incidence of cerebral edema in patients transferred from outside hospitals was much higher. And some of the things they postulate is we're not picking it up as early. So the kid's starting to get drowsy, starting to get sleepy, and no one's checking on the kid. So all these kids need frequent neuro checks. If they do start to go down, don't be afraid to give them something hyperosmotic, right? And then kind of general principles of, increasing intracranial pressure. This is bad, but once they get this far, they're in trouble. Okay, so think about this. I know this is kind of, I spent most of the meat on this because I think this is the most controversial and interesting talk. It's a rare thing. And I will say, so one of our pediatric endocrinologists is a big anti-fluid guy. He is almost, I would say, an anti-fluid zealot. This is the way he's been described. And I think one of the reasons why is kids in DKA get so much better, right? They look so sick, and then the next 2 days they look better. And I guarantee you that all your PICU docs, all your peds endocrine, they can remember the names, they can remember the family members of every one of their kids who died of cerebral edema. Because it's not supposed to happen. They're supposed to get better. right? They're supposed to turn around, they're supposed to go home the next day, they're supposed to not come back. But this is such a horrible thing, that's why it has such a sticking bias in their head. Be on the lookout for high-risk groups, right? Think about all these kids before, like, ooh, these kids are really high risk for it. And my final take on fluid is be appropriate with your fluid resuscitation. So DKA is not sepsis. You don't need to slam these kids with 80 cc's per kilo in the first hour. That being said, it doesn't make any sense to me, like CHLA, Big Children's Hospital, has a protocol for 10 cc's over an hour. Leave them dry as a raisin. When we know that dehydration, volume depletion is one of the risk factors. Like, what's up with that? If you go above and beyond, we had a case come into where I went to residency when I was a second or third year resident of a kid who was hypotensive, persistently in DKA, got large volume fluid resuscitation. There may be some special subsets, like a kid with sepsis and DKA, that need large volume fluid resuscitation. Document appropriately. If you're going to go above 20 cc's per kilo, have a good reason for it. It's kind of my take-home point with fluid. As long as you're in those guidelines, I don't think anyone would look back at your chart and say, "Ooh, you gave this kid too much fluid and you caused this problem." Okay, these are some studies. If you guys want to take a look, these I've referenced through. Questions? Great.
I have a question about substitute insulin for DKA.
I'm sorry, I can't hear you.
I have a question about substitute insulin in DKA.
Mm-hmm.
In Vermont, you are not allowed to transport the patient on an insulin drip unless there's a nurse in the ambulance. So working at a hospital where we have one doctor and 2 nurses on,
Yeah.
I will either give subcutaneous insulin or no insulin at all, depending on the timing of the transport.
So if it's kid, my recommendation would be no insulin and just get them shipped. Give your initial fluid bolus, we'll sort the insulin out when they get there. Because I'd rather, as much as I want to get them out of it, yeah, as much as I want to get them out of it, I'd rather have that than have them get hypoglycemic in transport. That would be my recommendation.
What's your trigger for giving mannitol?
It's a really tough one. It's not usually an ED problem because, as we said, cerebral edema presents about 6 to 12 hours afterwards. I think the first thing is you have to have a baseline neurostatus on the kid. So you walk in, a lot of them are sleepy and tired. My trigger is if they can wake up and talk to me and have somewhat of like a coherent conversation, they don't need mannitol. The minute that goes out the window, they wake up, they're not making sense, give it. I think the problem with mannitol is you run into a lot of the osmotic diuresis, so you kind of work against yourself if you're trying to fluid resuscitate a kid. I can't remember the last time I've given an ED. And probably that's a factor of working in a lot of centers with PICUs where they go upstairs in 2 hours.
So this is a question from Twitter. So given the potassium conundrum that you mentioned, do you have a recommendation on the paralytic of choice?
I'm sorry, what?
Do you have a recommendation on the paralytic of choice if you're intubating a kid given the issues with potassium?
So, no, I don't. I would say there's lots of stuff about not using succinylcholine in kids. If all you got is succinylcholine and that's all you know how to use, I would much rather you get your best shot and intubate the kid than try to mess around with something you don't know how to do. So a question I often get is, well, should I try an awake intubation? Because I don't want to paralyze them. I would say no, because if you don't do a bunch of awake intubations, your likelihood of success is very low. Personally, I'd probably use rocuronium, but again, if all you have is succinylcholine and that's what you're most comfortable with, you'll probably get away with it. Rocuronium first, but again, I guess my first recommendation is be comfortable with what you're intubating, because the real thing that I'm scared about is the apnea side. Questions, comments, concerns? Okay. Thank you, everyone.
Welcome, David Nelson. I'm a pediatric emergency physician from Las Vegas. I see some faces out there. You've been here before. This is my 16th year, I think. And I'm happy to be back. This lecture is kind of shortish, but we've broken it up tonight and tomorrow night. And it's case-based. And my point with this is we're going to look at some rare and serious conditions that present as common things, and then we'll figure out why they fall out of those categories and make you think about the things that are more serious, less common. And then I want you to think about it being a pediatric EM physician. And what I mean by that is, and I teach my residents this too, is anyone can take care of a sick kid. Anyone can notice a sick kid. It's easy. The janitor can tell you the kid's sick. What I'm trying to do is teach you to find them before they get super sick, so you don't have to work too hard at it, and they don't have to get too sick. So what's different about these cases is there might be something a little bit off in the history, in the physical exam, maybe the vitals are off, and then maybe you've done some treatments and it's just not quite working out, and so you need to go back and reassess again and say, what's different about this than the other 1,000 kids I've seen just like that? So the first case, let's see if I can drop this a little bit without too many people falling asleep. I too have chocolate. If we need anyone now dropping, you're dropping right there. I see you need a chocolate to start with. All right. So 3-month-old, otherwise healthy, cough and cold, symptoms for 5 days, feeding well, no fevers, no vomiting, diarrhea, good urine output. There's the birth history, term C-section, 7/11. Let's see, vitals, 99. Anyone dislike those vitals? No, none of you guys like kids. I know that. 150, holy crap! No, look, I'm breathing right. All right. Those are all right vitals, don't you think? All right. Awake, alert, well hydrated. Lungs, a little expiratory, bronchi, wheezing, no retractions. There's a couple little babies in the hallway. I mean, have you seen them? I see them out there, and I'm like, oh, I don't want to work. I'm on vacation. So what do you think? Just thoughts, quick one. I mean, run-of-the-mill bronchiolitis. Thank you very much. I'm coming with a handful of chocolates. Where are we going back there? Right? So run-of-the-mill chocolate. Now, I have 2 videos here, and I want who said run-of-the-mill bronchiolitis? Yes. So yes, we see this. We love it. We love it. It's right now, big season, right? Big season. Up there with flu. Flu A. Everyone seeing flu A? Aren't you glad you're here? So you got a couple days of no flu A? I love it when I talk to the parents, so, you're going to get a flu shot next year? No, it gets me sick. Well, enjoy your next 7 days. So when I watch these videos, a couple things. Listen to the sounds and then think just real quickly, sick or not sick. You're all very good at this. In seconds, you can decide if someone's sick or not sick. Stop feeding me! So did you hear the wheezing, the expiratory wheezing a little bit? Audible expiratory wheezing. Sick or not sick? Not sick. You can hear noises. There's something going on, but not sick. Now, I mean, granted, the kid has to pull away a little bit to feed, but feeding well, doing well, not too bad. All right. No transport! What's the kid got? I don't know. He's out of here. Don't even check him in. So he's sick, right? His eyes are closed. He's wheezing. He's sick. So he's got a good chance of ending up buying a tube, but with high flow now, high flow's kept the tube away. High flow should be your friend for this. For these sick kids, it's really helped out a lot. Fluids. So let's just talk a little bit about bronchiolitis. Run-of-the-mill bronchiolitis. So the diagnosis. Do we know the diagnosis? Do we test for RSV? Does anyone make you test for RSV? Anybody? Not anymore. A little bit. And you tell them it doesn't matter.
Yeah.
And they tell you.
I'm still young at it.
They tell you you're still young? They pulled a sunny boy? Wow. Gray-haired people do that for you? Wow. So, chest x-ray?
No.
I mean, for run-of-the-mill. Not the sick kid. The sick kid's easy, right? We're everything, do everything. the run of the bill. So the statement paper from the AAP 2014, clinical diagnosis, management, and prevention of bronchiolitis. 1A, clinicians should diagnose and assess severity based on history and physical exam. Shove that up there. 2, risk factors. Use your risk factors to decide, do I need to do more things? Meaning, do they have heart disease? Are they premature? Things like that. Then I might have to do more tests to see where they fall in. Are they being admitted? Are they going home? And then finally, clinicians should diagnose based on history and physical, not routine x-rays and labs. All right, easy, done, bronchiolitis. Easily diagnosed. Management. So let me know if I forgot anything here, right? Oh, you know which one I didn't put on here? Mother's kiss. Do you know what that is? When mom blows into the mouth of a baby and the snots come out. Mother's kiss. Right? You're nodding. Have you done it?
No.
Okay. I mean on your own child is what I meant. It almost makes me throw. I can't stand it. But I don't think I missed anything here for treatments. That's just about everything. Anything else you guys can think of that's been tried that, you know, if you're old like me, we've tried everything, it was no good, and now so. According to this paper, here's your treatment options. No, maybe, okay, suction their nose. Go home. So, let's see, nebulized hypertonic. So first of all, let's start at albuterol. Don't use albuterol. Oh, come on, I used it the other day when I worked. You guys use it. Why do we use it? Because we got nothing else. Man, suction your kid's nose. See you. That'll be $250. Thank you. Don't write my boss. But, I mean, we try it. Now, you got to be careful when you try it. You got to be prepared because almost every parent's going to say, oh, yeah, way better. Can you get me a machine? So albuterol. Now, again, if they're super sick, you're going to try anything. You're going to try it. But just so you know, this gives you some ammo that you don't have to do anything for those well babies. You don't have to. You don't have to try an albuterol. You don't have to do, definitely steroids out, antibiotics out, oxygen if they're low. I had this conversation 100 times last week. I'm so glad to be here. No patients for a while. Yes, ma'am. Yes, your child's been sick for a couple of weeks. I know we don't do anything. We're terrible. We're people. I feel for you, but your child doesn't need oxygen right now. They don't need IV fluids. Yes, we have a super sucker here, but you can't take it home. So there's our management for bronchiolitis. So our patient, our 3-month-old, diagnosed clinically, suction his nose, anything else. It's subtle. I don't think you're going to pick up on it. It was on our first piece of paper with all the vitals and stuff. Does anyone have a baby at home? Baby? Or yeah, how many months?
Just a year.
Just a year. So weight in a baby should go from birth weight in a year should, any idea, anybody? Should triple. You knew that, just nod, triple. And then by 6 months should double. So this baby's birth weight was 710, and look at him at 3 months. So you guys have growth charts in all your EHRs and your EI. You might, you don't ever look, but you might. So this is going from the 50th percentile, dropping off the curve by 3 months of age. Also known as failure to thrive, which usually is, ka-ching, I'm done with you, you're going into the hospital. Thank you, have a good day, right? If someone sends me a patient, I think they're failure to thrive, I'm like, so do I, thank you, you get admitted. Not much time in the ER, but this is bronchiolitis failure to thrive. So, on a reevaluation of our patient, after the RSV was done, oh my gosh, you astutely notice a murmur. You've all done it. You've all gone back. Someone else pointed something. You saw something. You went back and you're like, oh, yeah, there it is. I hear that murmur now. I didn't hear it before. It's too wheezy. It was too wheezy. Now what do you want? You want anything else? X-ray. There's your X-ray. What did oh. Owen. Big hearts. Big heart. Peter, is this a big heart?
Yes.
How do you know?
It's big.
Get an ultrasound. That's why I set him up for that. Get an ultrasound. Chest rate, cardiac echo, large VSD, congestive heart failure. Son of a bitch, how are we going to find this in RSV season? So quickly, a congestive heart failure. The blood's going left to right. Pump overload. It's not a crash thing. It's a slow process. It usually presents by 4 weeks in these young kids who come in sick, but it can spread out over the year, and then even occasionally older can present as well. So what do we see? Well, again, our kid had poor feeding, failure to thrive, but look, tachypnea, tachycardia, that's a cold. Physical exam, again, heart murmurs are hard as heck to hear in a busy emergency department. There's other noises. I mean, they are. Rales, rhonchi, wheezing, there's our broncholytic. And then I defy anyone to say that someone has a 3-month-old has hepatomegaly. I mean, that is not something you're going to pick up. But as they get sicker, it's a little easier and easier. So certainly not easy. So for this kid, what was different about this broncholytic was the failure to thrive, and then the heart murmur. So in the big broncholytic world, yes, we see hundreds of these. Just look for something a little bit different, and then do the testing. But be aware that, I mean, in this, when the American Academy of Pediatrics just gave me permission to do nothing. So some of these, in the old times, we'd say, give an albuterol treatment, do RSV testing, get a chest X-ray. You might have you'd pick it up that way, but we're also trying to be better clinicians, do less testing, things like that. So, good luck. You'll get it. You'll get it. You'll get it. You will. All right. Next case. Barky cough. Who wants an easy chocolate? No one's going to say it? Crow! There's an easy chocolate or two. Here, ready? So, 18-month-old presents to the doctor's office in respiratory distress. Doctor calls EMS. EMS picks up the kid. I get the call. This is EMS. We got a child with stridor. We picked him up at his doctor's office. We gave him a racemic epi. He's now breathing better, satting 100% on Ravera. He hits my AD on arrival. He's in no distress. He's got some barking, coughing, just a little bit. Very mild stridor when crying, but not at rest. All right. So, this patient, let's see. He, stridor, history is obtained from a Spanish-speaking mother mostly. And yo hablo español muy bien. I speak louder and they understand me better. Otherwise healthy. He's had a few cough cold symptoms for a few days. And so our diagnosis talked about it. Probably croup. Our management of croup. Anyone? So I threw out no stridor at rest, because stridor at rest is the clincher for which treatment? Stridor at rest? Either steroids or epinephrine. Which is stridor at rest?
Epi.
Epi is stridor at rest. So our kid had no stridor at rest. What are we going to give him?
Well, we need to watch him for 3 hours. But he's had the epi.
If you give him, right, you could, right? He got epi, so we can watch him for a few hours.
3 hours.
I'm just going to say by the time everything, a couple hours went by. Now that's a good question. Does anyone have policies in their ED on how long they watch them? In the old days, it was 1 epi and admit. The timeline has come way down. Now in my ED, it's about 2 hours. And that's something we chose. There's nothing out there that says you have to watch them for X amount of time. So you can go back and rock their world and say, I'm kicking them out after 2 hours. Just saying. You're not going to do it. I can see his face. He's not going to do it. This guy's crazy. So our child, dexamethasone, observation, 3 hours, and then go back, follow up with your regular doctor. You've done it 100 times. You're going to do it 100 times more, right? All right, so what's different here? So I got 2 cases of some stridor here. Again, I want you to think about sick or not sick. That's stridor, that's noise on inspiration. So it can be confusing, right? Parents going to call that wheezing, but that is stridor. I'll play it again. Just listen, sick or not sick? Come on, he's cooing! He goes great! He's not sick. He's cooing! All right, not sick. Still sick, he'll hectus, he was working. He got a couple racemics, he got to stay with us. So there's some different varieties of croup. And remember, croup is inflammation of the upper airways. It's the younger ones. I explain it to families. Adults get the same virus as croup, but you don't have the noise because your airway's bigger. So the swelling in the airway, it's going to cause that disruption of the airflow. I don't know if you've heard this before. In the X-ray, it's supposed to be rounded up here, and it's pointy like a steeple sign. Couple different viruses. I'll see kids several times through the winter, and the parents will say, what the heck's going on? I say, multiple viruses. Now, remember, in the differential, aspirated foreign body, epiglottitis, bacterial tracheitis. That is part of my regular differential medical decision making, right? Put that chart from a 4 to a 5. It's not why I do it. Don't do it to add on. You know that. But I always say viral croup, no history for aspirated foreign body, no clinical evidence for epiglottitis or bacterial tracheitis. Any epiglottitis, I've never seen a child with epiglottitis. I know in the adult world you're starting to see them more, right? Anyone see epiglottitis? A kid, pre-vaccine, or an adult recently? A what? Long time ago. In a kid? Yeah, there used to be protocols at the hospital. If you thought a kid had epiglottitis, you don't touch them. They go straight to the OR. They get intubated in the OR. Now they don't have any of those such protocols, so it would be a little bit of a cluster if you said, "I got a kid with a bad airway. Come help me." Epiglottitis protocol. Like, we don't have that, old man. So our croup patient came back 2 days later for a recheck. All right, wonderful. They never come back. They never do. Oh, he's doing well, some coughing, no fever, no respiratory distress, feeding well. Excellent. Everything's good. Follow up with your regular doctor, come back for any concerns. That's an airtight chart. All right, so I'm getting ready to send the kid home.
Was there an interpreter used?
I'm getting there. Excellent. No chocolate for you. I did the same Spanglish on this visit. We were simpatico. She might have brought the 8-year-old to help. My legal department is good with that. So nurse's note. Patient here for follow-up, for croup visit, no distress, doing well, no recent travel to West Africa. No thoughts of suicide. Excellent. Medications, no weight, no distress, lungs, no wheezing, no rotation. Decreased breath sounds right base. Exactly. What does one do with a nursing note? Do we just up and up outright and blow it off? That's never good. Because nurse's favorite comment, doctor aware. Do you override it? I'm the doctor. My note is, I'm trumped the nurse's note. There was no such thing. Everything's good. So I went back and listened to the patient. Son of a bitch, there was the brain base was decreased. Well, don't worry, there was. Not that I should doubt my nurses, they saved me 1,000 times in the past. So, decreased breath sounds, right base, Spanish interpreter, history of choking on something at home, then respiratory distress. So, the whole time, from the doctor's office to the paramedics to the first visit, this was my kid. To the second visit, to this. So I got the interpreter, we got the story, the kid went and got a bronchoscopy, and he had a bean in his lung. He had choked on a little bean, and the reason, he must have had a little inflammation when that happened, and he sounded like croup, and he got treated like croup, and he got better like croup. Now, he would have come back a month or two later, or, multiple repeat pneumonias, and it eventually would have worked out. But, would have. But, so the issue here is a couple things. I remember this day. I remember it. I remember what room this kid was in. This was a long time ago. I remember everything about it. It was busy. It was a busy day. And that works well on the stand when you're getting sued. I'm sorry, Your Honor, it was busy. I'm sorry. Oh, it was busy? Case dismissed. Everybody out. So take a little time, and then the language thing. I think everyone knows this. Every hospital has access to either people to interpret or the phone. You can get any language in the world on your phone. On the phone services, and I might have drummed on this before. If your hospital doesn't have this, you're going to get in trouble with something. And we're seeing so many different languages from so many different places. It makes sense to get a good history and just knock that out of the park from the beginning. All right, hold on. I can bring the whole bag of chocolate back to the Spanish interpreter. Last case. 8-month-old, vomiting for 8 hours, 6 times, non-bilious, non-bloody, little tactile fever, a little loose stool, slightly decreased number of wet diapers, and vitals, 8-month-old, look all right. Awake, alert, looks good, everything looks good. Vomiting. All right. Anything? Vomiting. We see it 1,000 times. Diagnosis, labs, imaging, treatment. Vitamin O. Anybody for vitamin O? So, it's rotavirus. That's rotavirus. They're puking. They're among other kids with rotavirus. They're vomiting. And the brother has it, the sister has it. So, vitamin O. Yes? What do you mean? We should have this in triage. That and Tamiflu right now. So, now I've been asked this before. My comfort level for Zofran is about 6 months. I don't like it. There's no literature out there. It's just under 6 months, I don't want to hide anything. So over 6 months, about 6 months to a year, I'll give 1 dose. I'll try it once. I'm not going to multi-dose it. I'm not going to send you home with it. I'm going to see if I'm going to get a little something. So this one, vomited. All right, so this happens sometimes. Doctor, I just gave it. Can I give a second dose? All right, I guess. So, but not this case, but that happens. You've heard that before. Can I give a second? Sure. So he vomited. This is a little one, and it was vomited. They vomited during their PO challenge. So I'm like, you kind of failed your PO challenge. This happens. It's part of my algorithm. You're getting IV fluids. There's your 20 cc per kilo bolus. And then you got a good blood sugar. There's some electrolytes. Not too bad. The CO2 is a smidge low. Okay, you've been vomiting. All right. So PO challenge, tolerated twice, then vomited just a little. Just a little. Just a little, doctor. Just a little, doctor. And then this one, parents want to go home. I guess. Well, you're hydrated. Your stomach's soft. You're good, right? So because I'm still a little uncomfortable. So, because of the vomiting, right? I just gave IV fluids. Why are you vomiting still? Just a little bit. There's your x-ray. You like it, you don't like it. It's full of air. Peter, you like it, you don't like it.
It's an X-ray.
It's an x-ray. You don't believe in x-rays? No? Well. All right. So, bedside echo. So Peter, what do you got there? There's your echo.
I have a traducan sign.
So, what'd you call it?
It's a traducan sign.
Traducan sign, the one inside the other. This one right here?
The duck and the goose.
The duck and the goose all layered in there. I'm gonna just, that's the target sign. That's the one I'm going for. Not the traducan sign, but the target sign. So this one, Peter, correct me if I'm wrong, pretty easy to do, right? Run the transducer around, pretty easy to find. If you find it, you're done. It's easy. And now some of your radiologists might say, I want to prove it. Okay, fine. I had a case once where I said, I got this. And he said, it was 2 in the morning. Well, you know, our pediatric radiologist comes in at 8. And I said, no, we can't wait. I need it now. And he goes, well, I want it confirmed with ultrasound. And I said, no, I confirmed it. Do it now. And he didn't like me. But it's not about me, it's about my patients. So get it done. If that happens to you, push to get it done. So in this case, this kid did have an intussusception early, obviously very early, right? Here's an example of a barium enema, and right here is called the claw sign. So the enema comes in from the rectum and then meets the intussusceptum right there. That's the obstruction right there, and then that's both diagnostic and the BE is therapeutic as well. Do you know what you're using here, Peter? Are you guys using air, BE?
We do air first.
Air first. So, remember the history of intussusception is rhythmic vomiting or rhythmic crying. This kid is not crying, he's not screaming, he's fussy. And he's uncomfortable, and he's kind of rolling around and arching a little bit. But it's not too dramatic. But he goes from this, after about 5 minutes, to just completely quiet and relaxed. So don't think it's going to be bad on crying, quiet, and then every 15 minutes. It can be pretty darn soft, like this. And so you got to tease it out with a history. If you're lucky enough to see it, then you can see it a little bit, but it's not overt. You really got to pick the history apart. And then when you do think it might be, then you get in with your ultrasound. So typically younger, it's that telescoping of the terminal ileum through the ileocecal valve. Most common obstruction in kids. Intermittent rhythmic crying. So you're going to hear this all the time. He was crying all night. Okay, what's the longest he cried for? Cried for an hour, didn't stop. Okay, what's the longest he didn't cry for? Maybe 2 hours. Well, that doesn't fit into the intussusception scenario as he cried 20 minutes, stopped 20 minutes, cried 20 minutes, but you might not get that. So the other thing is, might be completely normal. I've had kids that every time I'm in the room, they're looking great. And I come out and I say, doctor, the kid cried when you were gone. And then there's a lethargic presentation of intussusception that if you've been doing it long enough, you might have seen that. I think whatever it is, their endorphins, if they've been sick for a while, they get really lethargic. They get tired in between. When I was a fellow, I was doing an LP on a child, and they passed the bloody stool. So, and they made themselves more obvious, so I took the needle out and said, all right, BE time. This clinical stuff, this stuff is late findings. Mass in the right upper quadrant, you know when I felt that is after the test. Oh yeah, I feel it now. Oh yeah, I got it. Heme positive stools is a later finding, but it's 75%. So you can do the rectal. And then this current jelly, that is a late finding. You don't want to wait till the kid has that. Quickly on Zofran, I love it for kids. I'll use it. I use a dose in the ER, maybe send them home with a couple doses. It doesn't really mask other things. I do a little fluid challenge afterwards. If they vomit with Zofran, something's up. You either, now, are there plenty of gastros that they vomit with Zofran? Sure, but I'm going to move on and give them IV fluids. I'm not going to just take it and say, oh yeah, take some more Zofran at home, go ahead. Now, if I give them Zofran and they're still vomiting with IV fluids and Zofran, now I'm worried you're not going home. You're staying, we're working something out, I'm maybe getting an ultrasound on you, I'm doing some stuff. So take home on this kid is vomiting doesn't always equal gastroenteritis. If vomiting after Zofran, do a workup. If continue to vomiting, then bring them in and watch them for longer and do more workup. So quickly on these 3 cases so far, rare conditions can present with routine stuff. When something's not quite right, that little voice in the back of your head, then take it up, think about it. A lot of this stuff is not, the other thing about the Peds ER is we don't get labs and triage. Everyone's seen first, then labs are drawn. So a lot of this stuff, good history, physical, and then a reassessment, and then use interpreter translation services. Good job. And look at that. 15 minutes early. Put that on your eval. Thank you. So I got more cases tomorrow night, similar stuff. Hope to see you tomorrow. Let's go have a